On this special episode of the ASC Podcast with John Goehle, we meet with the leadership of the New York State Association of ASCs during the Spring 2021 virtual conference and discuss New York State ASC issues and interview various speakers at the conference.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. This episode is sponsored by Ambulatory Healthcare Strategies. The ASC regulatory environment is increasingly challenging, but organizations that outsource their regulatory oversight to Ambulatory Healthcare Strategies have an edge. HS works with ASCs to oversee their quality improvement program, run their meetings, develop educational programs, and always be prepared for surveys. For more information or to schedule a consultation, visit our website at ah-strategies.com, email us at info@ah-strategies.com, or call John Goehle directly at 585-594-1167.
Welcome to episode 134 of the ASC Podcast with John Goehle for June 28, 2021, recording from our studios in Spencerport, New York. This is Susan Cronkite, Chief Researcher for the ASC Podcast with John Goehle and a Senior Nurse Consultant for Ambulatory Healthcare Strategies. Joining me is John Goehle, the owner of Ambulatory Healthcare Strategies and recognized as one of the nation's leading experts in the ambulatory surgery industry. Mr. Goehle is the author of over 10 books on the ASC industry and a frequent industry speaker on regulatory, accreditation, and finance issues.
So we had a great opportunity to present the New York State Association of Ambulatory Surgery Centers virtual conference earlier this month in June, and we had an opportunity to interview the leadership as well as do like a roundtable with some of the speakers there. So we had a lot of fun, didn't we, Sue?
Very interesting, and it was a great conference, even being virtual.
And I did get to try out my new sound effects board here, as I've been speaking about quite a bit lately. But we did have very good attendance, excellent attendance, almost close to 100 people at one point. So even though I think people are tired of virtual conferences, they're still attending them and, hopefully learning a lot from it. Yeah. So it was a great conference. We did have some technical problems, and you might experience a little bit of sound quality issues during the recordings that we have here. But if you are a member of the New York Association and you sign up for the conference, you also have access to recordings, video recordings of the conference. So if you are a member, make sure you visit the website and log in with your credentials, and you should be able to have access to that. So our first speaker was John Van Valkenburg, who is the president of the association. So let's listen to our discussion with him about what's going on with the New York State Association. So I'm here with John Van Valkenburg. He's the president of the New York State Association of Ambulatory Surgery Centers. Sue and I have interviewed John quite a number of times in the last, how long have you been president, John?
It feels like it's been forever, but I believe we're going on 4 years now, or about to finish up 3 or 4 years now. So it's been a little while, since 2018, I guess.
Yeah, and it's been an easy ride for you. You really haven't had much to do during those 4 years, right?
No, it's been very uneventful. Obviously, I'm sure you can sense the sarcasm.
Yeah, right.
But it's been a crazy 3 years. A lot of difficult things, but a lot of great things as well. A lot of great developments with the state association.
Right. Well, thank you for all the work that you've done. I work with a lot of state associations, and you literally communicate with the membership, I would say, on a daily basis, which is incredible and it's very much needed by our membership, I think, with everything going on. And, of course, we're in a difficult state. I mean, all states are difficult, I think, right now during the pandemic, but New York has certainly had its share of challenges during this time.
Yeah, absolutely. And that's something that we really, we've always at least since I've become president, we've really focused on trying to increase communication with our members. Once the pandemic hit, that's where we ramped it up to being daily, or in a lot of cases, multiple times daily, just because as new information was coming out quickly, a lot of questions, I was getting a lot of questions from members and trying to respond to them individually, but obviously that's inefficient and time consuming. And what I found is that the best thing to do is, a lot of people had the same questions. Right. So, obviously if we just update people on a daily basis and get all the information we have out there, and when we respond to questions, do it in a way that we're relaying that information to all of our members. I think it works really well, and we've gotten a lot of great feedback since we've been doing that. And obviously, Capital Health Consulting has been a key player in assisting us and with our communications and with growing the organization.
Yeah, they've been a great partner, and that was one of the best decisions I think the board made in the last 4 years is bringing them on board, and they certainly were extremely instrumental during the pandemic. So we just finished our second virtual conference. It went off very well, pretty much without a hitch, and the program committee is already working on the fall conference, which will be in person. Yay, finally,
yes.
Down in Tarrytown.
Yeah, we are very excited. This is something, all through the pandemic, the programming committee, and I know you're involved with that for the state association. We've been trying to figure out how we can, we've really missed getting together. We did also last fall did a virtual conference when we couldn't get together in person. As you know, and maybe not all your listeners know, New York State historically has done 2 conferences every year, in-person conferences, one in the spring and one in the fall. Last spring, we had to cancel the already planned one for the spring 2020 because of the pandemic, obviously. And really, in addition to dealing with everything that was going on with the pandemic and trying to assist all the ASCs in New York and dealing with the changes and everything surrounding the pandemic, we really wanted to continue that. Again, we had, with your help and with the help of the rest of the committee and our members, we put a virtual meeting together last fall that went really great. Mm-hmm. We got a lot of great feedback, and we were hoping at the time to be in person this spring. I think that was probably a little bit ambitious, but yeah. I know Jeffrey, and he's a pretty ambitious guy. Obviously, I think once the spring rolled around, or late winter, we realized that it wasn't going to be able to happen as soon as this spring. So, put together another virtual conference, which like you said, we just had a couple weeks ago now. I guess it was June 11th or 10th and 11th.
Right.
And it was a 2-day virtual conference. I agree. I thought it went off without a hitch. All the feedback I've gotten from the attendees has been overwhelmingly positive.
Right.
Also, a lot of excitement around what you mentioned. We've planned our fall in-person event. And to my knowledge, it's going to be one of the first in-person events, I think, within the ASC community. I know there's some other planned in-person conferences for this fall. Ours is September 29th and 30th in Tarrytown, New York. And we're really excited about it. We feel confident with where the state's at with regulations right now and distancing and, whatever might be thrown at us. We have the space and I think the resources available at that conference to comply with whatever the requirements might be at that time. I know now it's almost requirements off for that type of event, to be honest with you, restrictions off, but we'll see what happens this fall, but we're really excited about it. In fact, the people, our attendees from the virtual conference, a lot of them are excited about it as well. And we've already seen that. And just in the 10 days since we had our virtual conference, we've had about half the attendees to the virtual conference already register for our in-person conference this fall. So again, I think everybody wants to get back together and, get that networking piece going again. Obviously, we've been able to do a lot with education and communication with our members, but one thing that's really hard to do virtually is, get together and have a cocktail and, talk and really get to know each other so that we can develop those relationships among the leaders of ASCs in New York State.
So talk about the benefits of state association membership. Certainly, you've already mentioned a couple of them, the access to the conferences, and kind of alluded to those daily and they truly are almost daily updates that you send out. But what else? And also talk about how it really benefits the industry. Yeah,
absolutely. I mean, the benefits of membership for our members, I think, are plenty, and they're growing. As you mentioned, the daily communications and the newsletters. We also, every other week, it's a bi-weekly. Capital Health Consulting has a legislative update call where we go through what's going on in this New York State legislature and any bills that have been introduced or anywhere in the process, whether they're in committee or introduced or being voted on. And they really have a finger on the pulse there and it keeps us as facilities aware of what's going on and what might be coming down the pipe, and really give us the opportunity to be able to react or to be able to opine or to take effect on some of that legislation, and also so that our members know what's going on and we're prepared to react as things come. In addition to that, as you mentioned, the conferences, our conferences, we do invite non-members to come as well. There's a significant discount to the conference for being a member. I guess I would say, if you're going to come to the conference, the discount you're going to get as a member is the dues of membership will pay for themselves with regards to that alone. In addition to that, we're also working on some new and exciting things with regard to communication and an organization we're working on, an app, I guess, where members can communicate with each other and we can more easily communicate from them. As you know, we rely a lot on email right now, which, is great. Obviously, that's how a lot of people used to communicate. But, as technology adapts, there's better forms of communication and things that people are more used to with regards to apps and things like that, where we can really kind of communicate a little bit more directly with each other, and also just have access to more resources as far as who other members are, who people are. One thing we found through the pandemic, which I think has been great for our members and really great for our industry, is we've seen relationships develop among our members in certain regions. And ASCs have really bonded together to kind of react and to deal with this pandemic. Whereas, before, obviously we talked to each other and we got to with each other at meetings and everything like this. But, now these relationships, cooperative relationships, have developed where, you have ASCs in the same region talking to each other about best practices and what they're doing and how they're responding to these types of things and in those local communities. And I think that's been wonderful. Actually, there's been some success stories of members that have reached out to me and said, this has been great. Yeah. I've really been able to develop some great relationships with other ASCs and it's been really beneficial, and it's mutually beneficial. When you have those types of relationships, and that's one thing that the state association fosters. And then, you also mentioned, what we do for the industry. I mean, certainly there's benefits of being members, but it's important that you really all ASCs join the state association, or if you're in a different state, join your state association, because, collectively is the only way that we can really have an effect on so many things that affect us. And that's, legislation, regulation from the Department of Health. ASCs individually are very small and don't have much of a voice. But when we get together and we have a unified collective voice, then we can absolutely get the audiences that we need to be able to spread our message and to make sure that everybody knows what an ASC is and what all the benefits that ASCs provide to patients and to the communities where they practice.
And with the help of Capitol Health, we also have a line of communication with the state legislature and, of course, the governor's office with regard to upcoming legislation and even trying to push through and stop legislation depending upon what the needs of the industry are, correct?
Yeah, that's absolutely correct. And even beyond that, we also have a meeting coming up. We're working with the New York State Workers' Comp Board as well. And we've worked with them in the past and working with them again to talk to them, about things, like reimbursement, about how we can get, about how, one thing that their goal is they want to increase access, for beneficiaries, as do a lot of payers and as does the state. And, our messages is, well, there's certain procedures that we still can't do in ASCs for workers' comp, for example, because they're cost prohibitive. They cost more to do than what the reimbursement would be. And that, that by adjusting that appropriately, there would be an opportunity for actual, for significant savings to be able to take some of those outpatient procedures, what are being done inpatient out into outpatient or taking out of the hospital and into ASCs. And that's already being done, obviously, with Medicare and total joints and other things like that. So, and they realize that, but, they're the Workers' Comp Board and they need input from ASCs, really. And that's what we're doing. And that's why we're meeting with them. So I think there'll be some good developments there as well.
Can you tell our listeners how much it costs to become a member and how do you go about doing that?
Yeah, absolutely. So membership in the New York State Association is very affordable. It's $750 per year. we go by calendar year. So I know this year what we've been doing for new members is we're allowing a new member for $750. That's going to be their 2022 dues. And that will provide membership from now through the end of the year and then through all of 2022. So basically, you're getting 18 months of membership for $750. And then, again, ongoing, it's $750 a year. So again, I think most members would agree that that's very affordable. Even for smaller facilities, I think relative to other state associations and the National Association, it's a lot less. And I think you're getting a lot of bang for your buck. So
Absolutely.
To me, and it's not just speaking as the president, but speaking as a surgery center administrator, it really is a no-brainer. It's something you must do because I think the value and the benefits well exceed that dollar amount. And then on top of it, it's really that money's going to help our industry. And any help that's being provided to our industry is being provided to all ASCs and obviously our members in particular.
Yeah, and I can't emphasize enough how important it is to support both national and state initiatives. It's not enough to be a member of one or the other nowadays. Really, there's so much material.
Yeah. I mean, they're two, and it's interesting that, it's two different beasts, really. I mean, you're dealing with the federal government, the National Association deals with the federal government and everything around that.
Medicare.
And, but obviously there's 50 states and every state is so different. We were just talking about how different things are in New Jersey, which is right next door. And, they can't focus on those things. They're serving the ASCs throughout the nation. So, the state association is so important because, to be honest with you, as ASCs, I think you'll find regulation and legislation in states affects us in much bigger ways than the national legislation and regulation do, just because, again, it's different. It's different in every state. And, who knows what they're coming up with, next. And unfortunately, with legislation and probably even more so at the state level, there's unintended consequences. And sometimes that's why it's important for us to kind of take a look at what's being proposed and to bring to the attention of the people making the decisions that, hey, this is going to have an effect on ASCs, for example, even though that's, I'm sure, not the intention of the legislation. A lot of times that can happen and they don't see it. They don't realize it. And it really becomes incumbent upon us, because we're the only ones that are going to say it. If it's something that's going to negatively affect ASCs and that's not the intended consequence, but we know it is because we operate ASCs and we can say, hey, look, this is a problem because here's the effect it's going to have on ASCs, and make sure we educate them on that. And again, the state association is really the only ones that are going to be doing something like that, particularly when it's something that affects ASCs specifically.
Well, and over the years, you and I have been involved in the battles with regard to office-based surgery centers trying to get reimbursement for the technical component, basically, the facility fee. And then more recently, the ongoing issue of trying to force surgery centers to have a certified infection control coordinator. That's something that we know is on the horizon, but we're trying to make sure when it does happen, and it probably will happen, that it's done in a way that's going to work for surgery centers rather than, more complicated way like it is in New Jersey, for example. So all of those things are things that we monitor as part of our legislative initiatives.
Absolutely. Yeah, absolutely. And like you said, it could come from many directions. So, and that's where Capital Health Consulting comes in. I mean, they monitor these things. In fact, I didn't even know personally, because most of these things happen without much fanfare. In a lot of cases, a lot of these bills and sometimes not even bills, even just regulation changes that are done, for example, at the workers' comp board level. And, there was a change that was being made that I think overall was positive for us, but I think needed to be addressed in different ways. And that's what I was referencing with the workers' comp board. And, they brought it to my attention because they're keeping an eye on these things. That's what they do.
And we got to keep a very close eye on the HERO Act, which is coming up, which we have no regulations for. It's been signed into law, but we're waiting for the regulations to know exactly how that's going to impact us as well as any other. The HERO Act doesn't just impact healthcare. It impacts all businesses.
All employers, right? Yeah. Yeah. And to be honest with you, that's something that we've been looking at since it's been passed. And again, waiting for some type of, obviously the legislation's been passed, but looking at what the regulations are actually going to be and how we're going to comply. But, we're ready to do that. And I've already talked with Capital Health about, once we do get more information that we need to know how to comply, putting together kits for our members that just kind of assist in compliance with things like that. A lot of that stuff is just going to be plans and documentation and posted notices and things like that I think we can kind of help with, because like you said, I mean, it's a very general, piece of legislation that's directed at all employers, and obviously is going to have different impacts on ASCs than it would on grocery store or something like that. And that's where I think a lot of, the state's going to put out templates, to assist employers in complying with it. But my guess is, those templates are going to need some tweaking to really be applicable and, for an ASC. And that's what we're ready and prepared to do as another benefit to our members.
Plus, there'll no doubt be overlapping regulations that we'll have to deal with. So,
absolutely.
Oh, stay tuned.
Absolutely. Yeah.
Well, John, as always, it's been a pleasure talking to you. Thank you so much for your time, and thank you for everything you do for the State Association.
You're welcome, John. As always, I'd love to join your show and talk to your listeners and listen to your show as well. So thank you very much for all you do for the industry and also for your service on the New York State Association Board and our programming committee. And we're going to see you in September. I'll see you before then, but we'll definitely see you at the New York State in-person Fall Conference, September 29th and 30th in Tarrytown, New York. And if anybody has any questions about membership or about the conference, you can email info@NYSAASC.org. That's our general informational email address. You can send an email to that about anything. But again, we'll get you more information if you're interested in membership or the fall conference.
Sounds good. Thanks so much, John.
Thank you, John.
And next we interviewed Jeffrey Flynn, who is the program chair. Let's listen to his discussion about how we put together this program for the spring. And he also had a great conversation about what's going to be happening in the fall when we have our Roaring Twenties in-person conference out in Tarrytown. Let's listen. So Sue and I are here with Jeffrey Flynn, who is the program chair for the spring virtual conference. Hopefully, Jeffrey, this will be the last virtual No, I mean, I guess we're kind of enjoying doing these virtual conferences, but this better not be the only type of conference we have in the future. Can you talk a little bit about how we put this together and how we figured out who to bring in as speakers?
Absolutely. What we've been doing with this is trying to find out what relative topics our members want to hear. And certainly you've been an active member of that also, in seeking out different speakers and hearing from different centers from your clients. And then also talking with a number of the other centers around the state, we wanted to put together a program that people really could find informational. As I think we are slightly virtual conference fatigued, and we're certainly looking forward to our fall conference, but this has been an excellent presentation each day and very informative in each of the sessions. It's gone very well. The feedback has been wonderful.
Yeah, and thanks so much for all the hard work you have putting this together. Talk a little bit about the challenges that we're having right now with our wonderful sponsors, too, for the State Association.
Oh, and what's funny is a lot of them are looking forward to getting back in front of us, and we've had some challenges just kind of finding a way to include them. So we really didn't charge our fall sponsors for this we didn't ask for any sponsorship for this particular virtual conference because we wanted to focus on the members. So though they're going to participate in the virtual cocktail party and there'll be opportunities for them to say a few words about what they're going to do and how they're going to present in the fall, we're really looking forward to them in the fall. I think we're going to have our largest number of sponsors for the fall, as many companies are now allowed to travel again and getting excited about going out there again. I certainly know that I'm very excited about traveling again.
Absolutely.
Getting in person with people.
Yeah, drinking with all of our friends is always a lot of fun. So
yes. Yes, and our group's a fun group. We all know that.
We do that. That's right. Yes, I get no sleep during those conferences, it seems. So to that end, let's talk about the fall. What do we got planned? You got a Roaring 20s theme, which, when you mentioned yesterday that we're in the 20s, 100 years from the last 20s, I completely forgot that this is the new Roaring 20s. Go ahead.
Yes, it is, because that followed a pandemic too, and it followed a decade of tremendous growth and prosperity. And specifically to our industry, I think COVID has put us in a situation that we're about to be farther expanded. And, this is the ambulatory surgery center's time. It really is going forward. And I think we're really going to prosper. And actually, I think COVID made people recognize that we are really the effective answer to a lot of areas of in healthcare. So we're having a conference on September 29th and September 30th. That's going to be held live in Tarrytown at the Sleepy Hollow Hotel and Convention Center. We had a conference there in 2019.
Right.
So we're looking forward to returning there and then getting back to our larger things. We're going to have 4 tracks because we think we're going to have a lot more members going, a lot of issues coming up post-COVID. And that's what we really want to focus the conference on is to the future in the next several years of where healthcare is going, how ambulatory surgery centers fit in that. And hopefully we've put COVID-19 in the back rearview mirror.
Yeah, absolutely. Well, we were challenged. We were trying to get the state to come out and do some more some presentations with us virtually here, but that was not possible this time. But you're working hard to bring them in the fall, right?
Yeah, I think by the fall they will. Right now, it's just they're still so intense on just the recovery and COVID that nobody from the health department really is being allowed to go out to speak. They're really being directed to their set duties. We've seen even the regional CON person here in New York has been almost inundated completely on COVID issues.
Right.
So she's virtually been given a double job during the past 14 months. So we're looking forward to them returning to the conference, and the relationship we developed this past few years with the health department has been wonderful, and we're hoping that they will have a help table like they had at our 2019 conference. So everything I think is looking forward with that, and those challenges we're hoping are over by September.
Well, and again, we want to, I know I haven't interviewed John yet. I'll have John talk a little bit about the state of the state association. You are the vice president, of course, of the association. Let's just finish by encouraging people to become a member, not only for the wonderful conferences and the ongoing conferences that we do, but also for all the other benefits that come from state membership.
Oh, and that's true. And one of the things I noticed, and especially during COVID, we really did, and you certainly were a big part of that, we really became more of a tight-knit community. Yeah. And it's one of those things now that people, we're here to exist together. And I think we realize that more than ever. And the benefits of being able to call up, there's 1,000 years of experience within the board of directors, and everybody's very happy to talk in other centers. What works in different centers, what doesn't work in different centers. Some of us that are closer in vicinity to each other have started kind of sharing staff, with challenges and figuring things out with that. Those are all the benefits that the state association really does want to impart, not only advocacy for our roles, but to be helpful in still promoting that community that we've really been strong with. So as a vice president of the association, I really do urge centers in New York State to become members because there's a tremendous amount of benefits. And, if we're a phone call away from any issue you're hitting, if you hadn't dealt with that, everyone's willing to help.
And absolutely reinforcing again the importance of coming together. We'll try to have some virtual options for the fall, but there's nothing like being there in person, sitting next to your colleagues, being able to get their telephone number, and then just talking, even, casually about what's going on. You develop deep relationships. That's how you and I became friends. It wasn't because we talked on the phone. It's because we drank together, and I had to hear your laugh everywhere.
It's funny you say that. I've always said that if you sit down at one of these conferences with somebody across the table from you, just we're in a unique setting that within 2 or 3 minutes you've connected in a conversation because you're living the same life.
That's exactly
right. So I think that's coming together. That just makes us stronger.
As always, Jeffrey, it's been a great pleasure having you on the podcast here, and we'll look forward to seeing you live in the fall.
Yes, we're looking forward to having the podcast at the conference live and coming out live from there. Thank you very much, John.
Thanks. Take it easy, Jeffrey.
Take care.
Okay, let's take a short break, and when we come back, we'll listen to Lisa Altieri, who gave us a regulatory update for New York ASCs.
Thank you for being a loyal listener of the ASC Podcast with John Goehle. But did you know that you can enhance your experience and support the free podcast by becoming a Patron member? Patron members have access to ASC Central, an add-on service at a very reasonable price. Patron members have access to our regular drop-in virtual meetings where you can discuss issues that you are dealing with in your ambulatory surgery center with the hosts and other members. Members also have access to valuable member resources, including a document library with a growing list of resources, including the rules and regulations, guides to maintaining compliance, example policies and procedures, infection control resources, example risk assessments, example committee and governing body minutes, and over 60 disaster drill scenario kits and example forms and checklists. Members also have access to some of the virtual conferences that we have presented, including the Provider Credentialing Conference, which we offered in December 2020. It's a New World Conference in 2020. Infection Control in-Service to meet the challenges of COVID-19, and the ASC Mandatory Education Program, which is a valuable resource for annual education for your staff. Membership helps to defray the cost of producing the podcast, including the research staff, travel costs to conferences, equipment costs, and production costs. For more information, you may visit ascpodcast.com. To become a member, visit ascpodcast.com.
Things have started to change quite a bit in Albany right now, as everyone may know or may not know. So our agenda today is we'll just go over briefly the highlights of the 2021 legislative session, the resolution that actually got approved yesterday, which was memorializing August as the Ambulatory Surgery Center Month in New York State. So overview of the key legislation, overview of some of the other public health legislation and things that you may want to know or you may have questions for later. The regulatory landscape. So what's going on in Albany? What's going on within the Department of Health? And really, what do we think is going to be changing and the focus, where is it going to go on a go-forward basis? A lot of you know that if you have an ASC, you have to go through CON and FIPIC, and there's a lot of different changes happening right there at FIPIC. So after this, we'll have a few minutes, hopefully, for folks to actually ask any questions. So legislative session. So we started off session really gets kicked off when the governor comes out. It's the first Wednesday after the first full week in January, in which the governor kind of kicks everything off and the legislators come to town. This year it started on January 6th. And then we literally go through session where you have 2 to 3 days when they come into town and get out of town. Generally, the first few months is all about budget. Budget really starts around August, September, and October. So that's when discussions are happening about things and priorities that folks may want to see in the budget. But the actual focus on the budget that the governor puts in, the executive budget, we actually start talking about in Albany with the legislators and with the governor's office and the agencies, Department of Health, about things that we like, don't like, and then other ideas. We present those other ideas to the legislators to see if there's things that they would like to put in their one house budget bills. So, and then after April, so after the budget passes, which is needs to be due in New York State and balanced on April 1, after that, then we start the non-fiscal issues or things that won't really have a price tag to them. Usually session ends in New York, usually around between like the third week in June, 19th to 20th, around there. This year, it ended early. That being said, they still talk about coming back, which they may come back to take up a couple of different issues. And then we go to July and December. As I mentioned, that's the time that you actually start looking at pieces of legislation you want to work on next year, talking to people in their districts. Staff are still out there working from the legislative districts, and you're meeting with the executive staff about things that you may want to consider for the following year. So the retrospective from where we were 6 months ago to where we are today and the light at the end of the tunnel. I can't go into talking about session and the budget and legislative session without talking about COVID. We all know COVID hit us in 2020 and everything really shut down. That first year, there were no meetings. Everyone was just trying to figure out how do you connect virtually. And that first year in 2020 was really rough. This year, while it was better and we had actually ironed out some of the communications and how you talk to folks, how you have meetings virtually, I will tell you, it's still not the same. And especially when you're trying to talk to everybody via Zoom or the phone and you can't meet. So it's still been a really rough year for anyone that does this. Thankfully, we have a mix of folks that used to work in government. So it makes it a little bit easier because we have a lot of those contacts, but it's really difficult. So January, the state was facing a $12.5 billion budget deficit, as we all knew. Everything that goes into New York State, especially coming from the city, really just put a hamper on the budget. That, and then a number of different things that we actually collect taxes from, that also got shut down in 2020. So that all affects what's happening with the state's budget. The COVID-19 vaccinations began, as we know, the end of December, coming into January. And the legislature, once again, for the second session, came back to a virtual session. So in February and March, we thankfully had Congress passed and President Biden signed the American Rescue Plan, providing New York State with $12.5 billion. This was critical. So as we're all trying to work on items in the budget and the state's trying to figure out where they're putting dollars and where they're going to cut dollars, it's critical because everyone was kind of at their edge of their seat waiting for what's going to happen at the federal side. Because if we didn't get the money that we were hoping to get, which was originally we were hoping for $9 billion or $15 billion, which is what the governor wanted, if we didn't get that, there were going to be a lot of cuts. And there were lots of discussions on where that was going to happen. We knew that we were going to have some cuts to, Medicaid. And we also remember what they had done before with the MRT2, where they had those cuts in place already. So we knew that this second year, remember, Medicaid has a 2-year budget cycle. So this is the second year of the health budget. We knew there could potentially be more cuts. So that 12.5 really kind of kept us right on the edge of our seat till the end. And the governor and legislator focused on the enactment of the budget, which actually went over budget. So April 1, we were $212 billion state budget enacted. So it was over where the governor was. We were all a little surprised by that, but it happened. And so, one of the things was that there was a lot of arguing going on at the last minute. Some of the questions were we not going to make the deadline? As everyone may have remembered, certain things the legislative staff and legislators were saying, we're not going to talk about and put things in the budget that are really policy heavy or policy laden. We want to take those up after the budget. And in some ways they did do that because you saw that the cannabis, right, the adult use marijuana bill did pass before the budget did. That was on purpose because they felt if they tried to get it into the budget, they would have lost it. So, and it was very policy laden. That's why they did it. So lots of discussions going on. And I will tell you, since the budget passed, there's been a lot of policy discussions, many different people trying to get things done, some progressive agendas across the board. We saw a lot of scope of practice pieces of legislation coming out that we actually, for the first time, thought would actually get legs. And I won't go into those in any specifics, but if folks have any questions, you can always ask us. So in April, we had the start of looking at everything towards the end of session and those bills that were non-budget related, and the vaccination started to ramp up. So even though everyone else in the world was focused really on legislation, anyone that lives in the health and human services world we still had a lot of other things going on, not just legislation. So it was still busy for everyone. May, the legislature continued their work. And as everyone knows on the call, vaccinations ramped up, eligibility slowly started to open up, and the New York State was opening. Now, June, we are at 69.2% vaccinations. And so when we hit 70%, everything gets lifted. And as I said, the legislature is basically dismissed, adjourned as of today. So the Senate finished last night around 9:30 p.m. The Assembly didn't get out of Dodge until 4 a.m. this morning. So lots going on still at the last minute. So as of the number of bills introduced overall, as of last night, were 14,738. The number of bills passed by the Senate was 1,559. The number of bills passed by the Assembly, 1,054. Both houses, 892. And the number of bills signed into law so far, 112. We've had 2 bills vetoed, and there's a number of bills past both houses that aren't yet delivered to the governor, which was 771. So lots getting done. Recognition of August. So this was actually a really great thing. So one of the things is this is so in line with where I think ambulatory surgery centers are. So prior to COVID, ambulatory surgery centers have been growing. There's been discussions at the Public Health and Health Planning Council, as many of you know, discussions about different types of ambulatory surgery centers, as you all know. But, on an ongoing basis, at one point, hospitals are saying there's a lot of ambulatory surgeries coming up, and questions were raised by Dr. John Goehle at the Public Health and Health Planning Council in, I think it was 2020, early 2020, where he said, ambulatory surgery centers coming into certain areas of the state where there's only one hospital could actually, soften the stability of a hospital system. And so there were lots of discussions within the Department of Health. What's that going to look like? And so ambulatory surgery centers, the whole reason I'm explaining this is ambulatory surgery centers are growing. Everyone recognizes good quality, very good outcomes, excellent infection control, and you save money. And the most important thing in my mind, besides safety, is customer satisfaction. So there's a lot of recognition that they're coming, and everyone supports, especially the Department of Health, them continuing to come forward because we need them, especially where we're going with health policy and how we actually roll out serving more individuals and patients. So the reason, it's important is this year, even when there were some questions about how people were going to get reimbursed and some pushback for the hospitals, in some of the reimbursements, which I'll mention in a little while, for the ambulatory surgery centers versus the hospitals. And we know that there's a little pushback from all hospitals in general. It's important that we were recognized. And so in August of this year, there will be the Ambulatory Surgery Center Month in New York State. This is excellent. So Senator Rivera, the chair of the Senate Health Committee, Assemblyman Gottfried, who is the standing chair for health in the Assembly, both actually put this in for us. And it states, memorializing Governor Andrew Cuomo to proclaim August 2021 as Ambulatory Surgery Center Month in the state of New York, in conjunction with the observance of National Ambulatory Surgery Center Month. Whereas the state of New York takes great pride in recognizing certain months of the year in the hopes of increasing awareness of important medical conditions, education, treatment, and care. And whereas it is the sense of this legislative body to memorialize Governor Andrew Cuomo to proclaim August of 2021 as Ambulatory Surgery Center Month in the state of New York, in conjunction with the observance of the National Ambulatory Surgery Center Month. So it goes on, it's done. So this is actually a really great thing that we actually we got this, this recognition, given how late we got into the session And one, knowing where some of the other folks feel with the competition of ambulatory surgery centers. So key legislation that's passed. Some of these we've talked about on our biweekly calls, but it's important that we actually just mention them again. So the Sanders-Dinowitz bill requires insurers and health plans to cover screening, examination, and laboratory tests for colorectal cancer consistent with the American Cancer Society. This is a bill that we know we have PE, so we have the colorectal folks that are on, that are participating and are members of the ambulatory surgery centers. One of the things is that we really kind of worked really hard on this bill, getting it to the medical society, get it to all the other specialties to sign on, as well as the ambulatory surgery centers. We signed on to this as well to support this. It did pass the Assembly. It does not pass the Senate at this point. The Rivera-Gottfried bill, this actually provides that if a proposed midwifery birthing center meets the standards of national accrediting organization, that it is recognized by the Department of Health and then is proposed and shall be deemed to meet New York's requirements. For those of you folks that actually participated throughout the peak of COVID on our daily calls, this is something that we proposed to the governor's office and the department. Was in the midst of COVID, we were really trying to identify where our patients, when they're going into these hospitals, that we as ambulatory surgery centers could serve, even though we may not have emergent types of cases, we could still serve a subset of the population safely, healthy in the pandemic. And so this was something that actually was raised. And it looks like it's probably going to be moving forward. It passed both houses. I do expect this will be signed since Melissa DeRosa, who is the secretary to the governor, she was actually on the task force that brought this up after we submitted it to them. The next bill, Rivera-Gottfried, requires a healthy equity assessment to be filled in with the application for any CON applications, right? So, what it really is getting to is things that I believe are already required as part of the Certificate of Need application. How does this affect the community? How does it affect the patients? What's the need? How does it add and improve the access to healthcare in the community in which it's going to be built or served? And so, again, this passed both houses. I think this was really done based on everyone's identifying the racial disparities and some of the other disparities that we saw as part of COVID. So I think this was added to really beef it up. And then Prasad and Williams, this was to actually requires the Commissioner of Health to communicate all rules and regulations to govern the practice of all upper endoscopy procedures and prescribe an upper endoscopic patient bill of rights. This still remains in both health committees right now. So this hasn't been picked up. Key legislation, the Harkin-Bronstein bill. So this provides that the first opioid prescription to any particular patient each year, that actually has to be accompanied by an opioid antagonist, Narcan, if they have any of the following risk factors: SUD history, high doses of cumulative prescriptions, and then concurrent use of opioids, benzodiazepines, and sedative hypnotics. This is actually passed both houses, and it's pending to be signed by the governor. So the scorecard, the issue and the outcome. So these are some of the other things that we've been tracking and trying to keep everyone up to date on. Patient Medical Reduction Act. So this was basically trying to improve the transparency and the billing around facility fees and disclosures to patients. And it's applicable to hospitals, hospital-affiliated systems, and healthcare providers. So, that's something that's actually we've been tracking. The safe staffing in hospitals and nursing homes. So all of these things that have been we've been tracking, we've been updating everyone. So a plug for the association for those folks that may be participating that aren't a member. These are the things that we go over. So even though it may not specifically affect the ambulatory surgery centers, we do try to share it because there's a number of things that it could affect. And the more folks that are paying attention, the better off everyone is in the association. So the safe staffing actually been delivered to the governor. The New York Health Act, which is one single payer, that remains in committee. The CRNA scope of practice remains in committee. The OPMC reforms not adopted in the budget or post-budget accession. And then telehealth, there were some minor changes, but the full parity and some other items did not move. So regulatory landscape. There, again, lots of positives that happened this year, I believe, for the association. One of the things that came up, which we know about in COVID, was that in COVID, a lot of folks that were going through their regular screenings, normal procedures that they get done at the ASCs, they all had to put them on hold. One, because the ASCs couldn't work, right? Because if things weren't emergent, you couldn't operate. But besides that, a lot of folks were scared, and a lot of folks that were waiting for certain types of treatments, surgeries related to chronic diagnosis or acute diagnosis, they could actually be put off a little bit. And let me just correct myself, not acute, but we'll say some things could get postponed. And what started to happen was what we all realized would happen is that we had an increase in certain types of cancers, the stages of cancers, which we may have had earlier detection for. Additionally, a lot of people put some of those other surgeries off. In New York State this year, the Workers' Compensation Board issued emergency regulations on March 12th. And they basically amended certain portions of the New York State Codes of Regulations by adding a new section, which actually updated the fees for 29 procedures and those performed in a freestanding ambulatory surgery site or a hospital-based ambulatory surgery site. The reimbursement of the fees for those procedures will no longer be paid using the normal APGs that's been in place since 2019. So we looked at those, and this was a positive thing. And we also reached out as an association. We actually spoke to, in a letter, we actually put comments to this emergency regulation that were out publicly. We gave comments back, the policy basis for it. We explained, while we agree with the 29, that there may be some other things we'd like to talk to you about. And most of those were all orthopedic. So there may be some other surgeries that we'd like to, or procedures that we'd like to address. And we also think that it's important that we have an opportunity to sit down. So we sent all of those comments in, and we will be scheduling a meeting coming up with the Workers' Compensation Board. So this is something that's really important. The association, it's really, I always tell this to all of our clients, but you don't want one or two members. You don't want to stick your neck out and say, hey, this procedure I don't do, but, or you're not including my procedures, so I need you to include them. You don't want to stick your neck out by yourself. So if you're coming together as an association, together, collectively, you have so much more strength. And I believe in 2020, when COVID hit, the Department of Health and the hospital associations recognized the strength of this association because they adopted some of our ideas. They reached out to us during COVID, and they looked at, these are some of the things that we need to make sure we're paying attention to, because ambulatory surgery centers are a place where we need to have people and patients getting services. So this, I believe, is something that's very, very important. Again, as an association, you are with your group and your colleagues. You're not sticking your neck out on your own. It's an important thing. It's a reason why I think we should have more members. So FIPIC, I've mentioned it. We've talked about it. I've given you some of the reasons why I really believe there's a lot of focus on ambulatory surgery centers. So when I was on the Department of Health and we were focused on the Berger Commission, how do we change MRT, all those different things, we were trying to identify how do you get the right costs and the right outcomes for patients. while improving access. Well, that's an ambulatory surgery center. We also know that the overhead costs of having big hospital systems are expensive, and they have to run 24/7. So that was one of the reasons there's been a big push and support from the Department of Health and from health policy makers, because it just makes sense. So overall of the discussions in Public Health and Health Planning Council, FIPIC, a lot of the discussions have been, do we want all of these coming in place? Are they cherry picking cases? Do they get more money than we do? Do they get the same amount of money than we do? So there's always been all these ongoing conversations. And we've had a lot of opportunity. We went to the table in 2019, 2020 to talk about some of the things that the department and FIPIC were discussing. And we know that they're continuing to be approved because there's a lot of support. So when the workers' compensation, when some of these rates start coming out and people are looking at them and asking questions if they should be getting the same fees. And FIPIC's talking about all this. Most recently, at the last FIPIC meeting, 2 more ambulatory surgery centers were approved. And Dr. Gutierrez, chair of FIPIC Committee on Codes and Regulations, basically said that he had just had his surgery at an ambulatory surgery center, and he urged DOH and FIPIC to give consideration to have ASCs available or made available to provide emergency services during a surge. I think what he said too was he was attacked by an orthopedic because he had emergency surgery. So we expect that there's going to be ongoing changes and there's going to be opportunities for the association to actually speak to FIPIC. We also know that there are a number of ambulatory surgery centers that continue to get approved every 2 months as you see them to go to the final vote. So I think this is really important to keep in mind. And again, during COVID, ambulatory surgery centers stood up. They were there and they've been recognized and they've been counted on for being some of the folks that were actually there that were willing to step up and help the state, the commissioner, on how we could actually get more care out to patients, even if you weren't open. Okay, questions from the audience?
We do have one question.
Yep.
I have heard that there is regulations from DOH on mandating the older surgery centers to comply with the physical plant codes. Is this true? I think what they're referring to is there something from DOH saying that they would go back and not grandfather older surgery centers for some of the newest life safety codes?
So I will tell you, I'm not going to speak just specifically to that question because I'd have to talk to my friend Udo at the Department of Health. I will tell you that the Department of Health and CMS is actually becoming much more stringent on not grandfathering things in and not giving waivers for certain things. So that's been a huge issue coming up across the board. So I do think as we continue to have more ambulatory surgery centers, I think that could be a question and something that may be raised at the Department of Health level, if not by FIPIC.
Well, following with that, and of course, you have been talking to Udo about some of the issues surrounding our life safety, emergency electrical systems and things like that.
Yeah, so generator backup power and some of these things.
Battery operated systems, yeah.
Yeah, so I have to tell you, and it depends on where you are in the state, and John can probably tell you that too. It depends on where you are in the state and which surveyors are coming in, because that's definitely been an issue. So just as an aside, we've had a couple of DNTCs or folks that have actually said, well, they wanted an emergency generator. And then we've been working with the department to say, how about the emergency battery backups, right? And the different levels of backup that you need. I don't want to make across the board what's happening, only because I'm still getting some complaints from across the different areas of the state that different surveyors are asking for different things. What I will tell you is that there's a lot of focus on, besides infection control, is all your life safety code, emergency preparedness programs, your disaster plan, everything that has to do with your disaster plan, evacuation, backup, staffing backup, you name it, and infection outbreaks. One of the things that happened that's brought a lot of questions and discussions kind of around the health policy discussion in regards to life safety and infection control besides COVID has been some of the emergencies. Like, so for instance, in Texas, when we had the ice storm, right? So while it generates a lot of discussion at CMS where they start to review this, there's been a lot of discussions within the Department of Health on where do we have to get tougher. So I think there's going to be some ongoing conversations here. What I would suggest is that if folks have some difficult surveys where you think that there is something that may not be, it may be regional, maybe a regional citation du jour, or a regional, it may be different, it might be differently cited or viewed in one region from another. Please always reach out to John, reach out to the association so that we could try to see if that is the case and if we can help. John actually, John Goehle and some other folks, is when some of our members have had problems with getting their operating certificate or getting some of these other things done, it's not really hard for me just to reach out and get that, make that happen for you guys. I think we've been pretty successful in doing that for the members. Right, John?
Well, and actually, I do want to thank you, because every time I've had to reach out to you for that operating certificate, it has not been, I think the longest time was 48 hours, and that's probably because there was a weekend involved. So that you have been great in helping us out with that. And if you, and that's the benefit. Actually, I'm not even sure that those were state association members at the time. They certainly became afterwards because, we showed the benefit there, but I appreciate the help you've done. We've had a couple more questions here.
Sure.
Well, it looks like one question. Lisa, can you speak to New York State requirement for certification of technicians who perform sterile processing? And she's meaning, does it apply to those in an ASC or just acute care hospitals? Well, it applies to ASCs.
Okay. So I can't speak to this. I'm assuming that John can.
Yeah. This requirement's been around for a while. It's been around since 2015. With the exception of endoscopy, which is not sterile. So the state does require you to only employ people in sterile processing that are certified. There are exceptions. I don't want to go into the complexity of some of those exceptions there. Certainly reach out to us if you want some more details. There is an exception for endoscopy that they don't actually, I don't know if I'd say an exception. It doesn't apply to endoscopy technicians. So, and by the way, while we're on the subject there, at the same time that legislation came out, that was when the Surge Tech regulations came out that required surgical techs to be certified. Also, there is an exception for people that work for more than a year prior to January 1st, 2015.
So, until there's some more questions coming in, which I'll have, John or any of the panelists, any of the folks let me know about. I think it's really important. I can't overemphasize the position that the association's in right now. One of the things that when I was in the Department of Health, we didn't get a lot of calls and questions from a lot of the ambulatory surgery centers or folks coming in and meeting with us. It was really when they came in for approval, when we were at FIPIC, that we kind of had to deal with that. So I think what's really important that I kind of come back to is that during COVID at the peak, when the governor was saying that they were going to look at using anesthesia machines for ventilation, they were having some struggles. The commissioner's office and the governor's office reached right out to see, can you guys help? And at that point, there was this recognition that there's a capability for the ambulatory surgery centers to step up and be part of an emergent event. And the reason I say this is we've been working with reaching out with Haney's and working with them to talk about where we fit in. And I think this is really important because as these conversations continue to go on, we're going to be at the table where we can say, look, we can pick this up, or maybe a plan for a county needs to also make sure that the ambulatory surgery centers are at the table with the hospital, with all the other types of health and human service providers. And I think that happens in some areas of the state, but I can tell you from going through COVID and going through many, many different emergencies at the state level that has not always been the case. And so it's really been, I'm actually thrilled that this association is being recognized for not only of its ability, but its steadfastness, its ability to come together, to be organized, and to really make a difference. And so I think you're going to see more of it. I would guarantee you're going to see more shifts in the hospital systems, pushing more things outside of healthcare. I think a lot of it's being driven already by what we're going to see post-COVID, right? So you're going to see some of those larger systems kind of push things out because there's a lot of trust issues and everything else, right, from your consumers. But I also think from the payer side. So, the one thing that we learned is we've always known it, all of us, right? But dollar only goes so far. When you're looking at a pandemic, you need to utilize your dollars in the most efficient way. So that is going to be driving a lot of this. The other thing that I think I have a few minutes. The other thing that I want to raise that I really want people to start thinking about, which is really important, is what else can we do going forward to be in a better position if something like this happens? How do we show what are those other things that we can offer as ASCs to the community infrastructure if and when there's an event? And so I think that's important on a go forward basis, because I think that's where we might get a little bit more presence at the table. And like I said, we'll see I'd love to hear some more ideas from folks about new types of ASCs, because I do believe there's a real need. And if we can study that and take it forward, this might be the year we start to do that.
I have a question, which I think I'll have to answer here. Would there be a possibility on easing the requirements on patient escorts during discharge? Some patients live alone and have difficulty arranging for an escort, and some express they don't want their family exposed to the public during COVID-19. That's not a state issue. That's a federal regulation that requires that. Right. So it's nothing that Lisa can do about that.
And John, I also wanted to mention it's also a liability issue, obviously.
Yeah.
For facilities to be putting people. So, I mean, even if you could do that, that would be, I think, a very risky thing to do. So I agree.
Yeah.
We do have another question too. Not sure how we can answer this, but do you think the insurance companies, maybe John, you can help. Do you think insurance companies are looking at ASCs in a different way, possibly allowing better reimbursement, specifically for freestanding ASCs? Good question.
Yeah, and I'd like to address this because this is actually something they are looking at ASCs in a different way. I know some of you are very well aware, particularly if you're in the Anthem Blue Cross Blue Shield area, but it's become up and it's been a little controversial with hospitals lately. But so this is not necessarily from a changing a reimbursement standpoint, but some private carriers are starting to develop policies that are saying that patients having outpatient surgery, it has to be done in a freestanding ASC, not in a hospital outpatient department, because of the discrepancy in reimbursement. And because obviously we've proven over time, ASCs have proven over time, that the outcomes are great and that it's safe. And these insurance companies are aware, obviously, as is, Medicare and the federal government, that there's a huge opportunity to save when patients seek care in an ambulatory surgery center versus a hospital. So we've seen most recently Anthem Blue Cross Blue Shield, but some at the national level, some other carriers take this policy and they say, that if a physician wants to do the surgery, an outpatient surgery in a hospital, they need to get a special authorization, because essentially they treat it as a medical necessity thing. They saying having an outpatient surgery in a hospital is not medically necessary unless in certain circumstances that have to do with the patient comorbidities and the acuity of the patient's condition. So, it's a bit controversial, because hospitals obviously have a big problem with this, because they say, they're making a lot of money doing these surgeries, and they're saying we want to keep these, essentially it's not fair. But again, we've been in discussions with the carriers because they've reached out to us, and obviously I think this is something that's really good for ASCs. I think we're going to start seeing a lot more commercial carriers doing it. To answer your initial question as will that mean that reimbursements will improve for ASCs? Probably not, but volumes might, because now all of a sudden you might see physicians that don't have privileges in an ASC because they've done all their outpatient surgeries in a hospital, now having to come to you and come to different ASCs and say, hey, I would like to apply for privileges because, I'm having trouble doing my outpatient surgeries on my healthy patients in a hospital because their insurance carriers are saying it's not medically necessary, which I would argue is true. I'm not a physician, but I would argue is absolutely true. And because of that big cost discrepancy. So again, I think it's a great opportunity for us in that sense, because of the fact that ASCs are absolutely insurance carriers are absolutely looking at ASCs differently than hospitals, but in a good way.
So I just want to add something. 2 points. I think 2 points to this. So, recently, to what John just mentioned about the insurance company, especially one, I'm going to say Blues, right? That actually wanted to kind of like encourage or say you have to actually get all of your outpatient done in an ASC. Obviously, one of the large hospital associations were against us. And so it's important, again, that we reached out, right? And we reached out to the association and said, look, no disparaging comments on our ambulatory surgery centers because we do good work. 2, reaching out to the other hospital associations saying, look, we're not doing that. So we're not saying that. We're not saying anything against it or for it. We're going to just try to be silent on this because we believe it's about patient care. So I believe you're going to see a much more robust discussion about this in the coming months. As you start to see probably in the fall, folks start to talk about the budget. And the reason I say that is because if this discussion's happening and you have financial services, Department of Financial Services, DFS, that's actually involved in this, it's close to the governor's office, controller, looking at hey, what's our budget going to look like? Is this a position that maybe Medicaid takes for certain things? Now, we're a long way from there, but I'm just saying that is a possibility.
Can I ask you about infection control? There's been a number of attempts in the last couple sessions to require ambulatory surgery centers to have an infection control consultant or expert certified, similar to what New Jersey has. Do you want to talk about that for a second? I don't think it came up this year, but I'm not sure about that.
It didn't, but in the final rule, in CMS's final rule, for certain provider types, so nursing homes, they have to have in the final rule, as of 2019, they had to have an infection control preventionist, EPIC, right? APIC certified. So
right. Yeah, I see.
So I wouldn't be surprised because there's lots of discussions and lots of policies getting thrown around right now that is not the next requirement, not just ASCs, right? Not just freestanding, but also for the others. So I wouldn't be surprised. I also want to note, just because it came out last night, I believe, we've had the question of, okay, now that people are vaccinated, if they come to us and say they're vaccinated, right? Do we still have to test and all these things, right? And so I've been pushing, as we always can do, right? Consider yourself a professional nudge. And, something just came out for the nursing homes and assisted living and ACFs that they don't have to do testing on their employees every 2 weeks if they can prove they're vaccinated. And so I'm hoping we're going to start to have more of these other conversations and changes as well coming forward as the vaccination rates continue to go above 70%.
I guess just jumping back really quickly to this is something I wanted to point about the association and where it might get important is with regards to the policies of payers to directs to ambulatory surgery centers cases. I think one thing that we're looking out for and we're cognizant of, and I think there's a concern of, is obviously right now the hospital association that you mentioned is doing some publicity around it to try and put some pressure on an insurance company to not have that policy. There is some concern that pressure might move from one of PR to one of legislative efforts, in actually try and maybe next year push for a piece of legislation that says insurance companies cannot, make it more difficult for these patients to go to hospitals versus ambulatory surgery centers. And again, I think that's very powerful, and they have a lot of money. So, I think it's important that people understand that that's another example of something that as an association that we're keeping an eye on, that we're going to make sure that, should that messaging, instead of, if they start redirecting that from the public, which is what they're doing now, and it's probably not very effective, towards legislators and trying to drive some type of requirement, that we're making sure that, again, the interests of ASCs are being protected, but not just that the reputation of ASCs aren't being, slandered, I guess, by some of the messaging that might be going not to the public, but to legislators, and making sure the legislators are hearing from us and hearing our side of the story.
You have another question here. How about the expiration on the Excelsior Pass? What does that mean? Patients have to be tested? It's a great question.
Yeah, so actually I can speak to that too. So basically, right now, expiration on the Excelsior Pass should not be an issue for quite some time. Anyone that does have an expiration on it, all they need to do is go get another Excelsior Pass. Essentially, people who got one early, it was good for, I think, 90 days. And then if you got another one, it was good for 6 months. And now it's actually up to a year. So if somebody has an Excelsior Pass that says it's expired, all they have to do is get another Excelsior Pass and put it in their wallet. They don't need another vaccination. They don't need to get tested. Get a new one the same way you got the first one. Put it in your wallet, and that one's going to have an expiration date that is a full year out from when you had your second dose for that patient.
It's a timeout it's an app issue, not the approval of the pass issue, right? So that's what John's saying. If they put it in, if they took their pass on their application quickly, soon after they got their 2 week, they've extended it now. So it should be easy.
Okay, no, I just wanted to the point we were discussing before about driving patients into, with the insurance companies, driving patients to ASCs versus hospital outpatient centers. One way you do that, and there's many ways to do that, but the insurance companies need to look into the incentive for the patient to come and building that into the co-payments or the cost sharing. And we don't talk about that a lot. We don't get payers to participate in. I would love to have payers in this conference, or at least some representative of them, because that is the important, the patients look at, what is this costing me? And sometimes it's cheaper for the patient to go to the hospital. They don't have to pay payment or the coinsurance or what. They don't really care what the insurance company is paying the hospital versus. Now, the insurance company cares, but you also have to take into the consideration what's incenting the patient to come. And we talk about all those, the quality, the efficiency. You don't have to spend 6 hours in a hospital for a colonoscopy, and you can be in and out in 90 minutes and all that stuff. But I think that needs to be addressed and looked at and understood a little bit better, what the cost to the patient is.
So that's actually a great idea, is to see if we could get to meet with a couple of the big provider, like the payers.
Yeah.
So, or even the Health Plan Association to talk to them and bring them to one of our meetings or conferences. So that's a great idea because this is what they want. This is what they want. So that's a good point, Helen.
And to finish out our special New York State Association of Ambulatory Surgery Centers episode, we interviewed several of the speakers during the conference, and we discussed various issues that are of interest to not only people in New York State, but also throughout the country. So let's listen to this roundtable. So this is John Goehle and Sue, and we're here with some of the speakers from the New York State Association meeting in June. And I'd like to introduce Ann Geyer, Doria Cipriani, and Sherry Eckert-Burr, three of the speakers that we have. And also with me are Lori Rodericks and Jeffrey Flynn, who, Lori, of course, is our Director of Clinical Services for Ambulatory Healthcare Strategies, and Jeffrey is the Vice President and the Program Chair for the State Association. So welcome, everyone.
Thank you.
Thank you.
Thank you.
And I'm going to start with you. So the big question I have for you is, what was the biggest takeaway? You did a wonderful session on peer review, which is a really, really hot topic right now. You and I and Lori, of course, are our surveyors with AAHC. It's one of those common citations that we have out there for our centers. And when we were putting together the program for this conference, peer review popped to the top of the list. It's something we had talked about a couple years ago, Jeffrey, right? I think like 3 years ago. It was a very popular session, so we knew it was time to talk about it again. So can you kind of just lead off with some of the key takeaways that you had with your presentation?
Sure. Well, as a AAHC surveyor, one of the top 3 areas that I see that people struggle with is peer review. And I do a lot of speaking on peer review. And so this was a very timely subject. So in peer review, one of the citations that I give the most often, or consultative comment, but it's usually a citation, is allied health personnel are not being peer reviewed. And that's a key factor. People say, well, I didn't know I had to do them. There's a whole section in AAHC about peer review done on allied health. And then they don't understand who allied health is. If you use CRNAs or PAs, those are allied health. And you've got anybody who's a credentialed provider should be peer reviewed. Well, then they say, well, what kind of peer review? It's whatever your centers develop. So you've got to do it. That's a frequent place that people fall down on. The second one is that the administrator thinks that one doctor does the peer review, or that the administrator is responsible for doing all of the prep work for the peer review. No, that can be delegated, because when you're doing the prep work, which is pulling the charts, amassing the charts that have had incident reports, whatever it is, you can delegate that. That's a clerical function, and people don't realize that. And I go in and they're overwhelmed, the administrators are, during a survey, because they couldn't do it all. So I try to teach them how to do it. And the third part, and probably the key part, is to make peer review meaningful, that you have to have things that your doctors are going to buy in to reviewing, so that peer review is not a medical chart audit. And that's the big deal. It's not to make sure that all the forms are on the chart and everybody signed all the forms. And that's a common misconception. They don't understand how to create meaningful peer review. And what I did during the presentation was to give them some suggestions on how to do it. And I did it by anesthesia and I did it by surgery. And it involves the doctors that you have working with you. It's sit them down, get their heads together and say, what is important to anesthesia? What do we need to look at that can make or break whether you have a provider that's providing high quality care and a provider who's just checking off all the boxes? And with surgery, it includes things like transfers and things like that. So the 3 takeaways are: allied health has to be peer reviewed. And number 2, you need to delegate some of that work so you're not overwhelmed. Number 3, that you develop meaningful peer review tools, which I provided a lot of the tools during the talk for your use.
So, Ann, one of the other issues that I tend to find with peer review is that people feel that the chart reviews are the only elements in peer review. In other words, as part of the recredentialing process, that the only thing that they have done in the past 2 to 3 years, depending upon their state, is do random chart audits. And that really is not the total package for peer review. Do you want to talk a little bit about that?
I will. I think that what you're talking about is exactly what I was saying about the medical chart audits. First, you start with what I call your incident reports or your peer review for cause. Something happened, it involved one of your providers. That's done immediately. And you don't wait till the end of the quarter to do that. When you get the incident reports and you look at that immediately and you start making the adjustments that you need to make. Then you have, depending on how your policy is written, then you have your peer review that's, I call it to fill in the gap. Because if you have to review 2 charts or 5% in a certain time period or whichever is greater, you need to fill in that number. So that's where you do the random peer review on the provider. And you're going to have somebody, I just print out all of the cases that they've done for the last quarter, and you delegate that to someone to just randomly pull charts. So when they randomly pull charts, what are they going to look at? Well, you don't want them to just look at medical chart audits to see that all the blanks are filled in. You use the criteria that somebody's screening for, transfer would be a cause. You're looking for the criteria. So for anesthesia, if part of your criteria are vital signs that are out of the normal range that your anesthesiologists have set aside, they've named what those ranges are, that chart is going to be reviewed for anesthesia. And you put that form on there and what's appropriate for that. So it's not just going through and making sure that the charts are complete. And I think that's a common misconception.
Thanks so much, Ann. So next I want to talk to Doria Cipriani, who did a wonderful presentation on OSHA, which has been one of my pet issues lately, especially with N95s, which I'm sure you probably are tired of talking about, but as am I. Can you give us a feel for your presentation and the types of issues that you feel are the most important to get to our audience?
Sure, John. Thank you. I spoke about common OSHA citations relating to coronavirus, and there were a number. The most impactful in our ASCs had been the implementation of the respiratory protection program, to your point, right? And, in the hospital setting, a robust respiratory protection program was rather commonplace. Mm-hmm. And we in our ASCs had to come up to speed rather quickly to implement such a robust program as well. So there were a number of challenges identified, and particularly around bringing the respirators into our center. And, my biggest takeaway after doing the research to present was, don't be afraid of the OSHA and the other big resources out there to actually use them, because they provide really fabulous resource and information readily available to us, and particularly in a crisis situation, to just really network. We cannot do this alone, and we have to step through this together and really network. And fortunately, we are coming around to the other side and moving away from many of those barriers early on, getting fit testing supplies and actually getting our hands on respirators. So we're coming around to being in a better place. Likely we're going to be living with a respiratory protection program as part of who we are, which isn't a bad thing. And my guess is that most of us out there and here are actually getting quite good at it, or have gotten quite good at it, to be able to speak on it.
Yeah, we found recently when we go to our clients or new centers or during a survey that centers don't always know about the requirements for an N95, or they're still putting their N95 masks into a paper bag thinking that that'll be okay. And we know that we're kind of past that period right now. And I'll tell you, the other thing that I've been running into, I had this long conversation with one of our centers the other day, and they said, oh, yeah, we were using N95s. I started off in this whole conversation about what you need to do. And then I actually looked at one of them that was wearing a mask, and it was a KN95. And I said, oh, forget everything I just said. You're not wearing a respirator. So I agree with you. So let's talk about that for a second here, is that as we move forward, I'm afraid, I think we all agree that we're not done with pandemics. This one's over with, but I think we've learned that perhaps we should have a respiratory protection program in at all times, that perhaps we should keep our supplies for fit testing around and do those medical evaluations, all those elements that are required for this, just so that we can be ready for the next period, and buy the supplies now for the fit testing, buy the N95s while we can get them quickly. So you want to talk a little bit about that?
Sure, I absolutely agree. I think, we learn from, teachable moments and we move forward from them and create that team and have a robust team who is familiar and your go-to people in your center who have their heads, if you will, wrapped around the program. And we don't want to be caught in a place where we were, 13 or 14 months ago where we could not get our hands on PPE. If we think back a few years ago when Ebola arrived on the scene, fortunately, it did not get to the place where coronavirus had, and we all had become really familiar with donning and doffing PPE. So that is a common phrase for us now. And I believe if we forecast for the respiratory component of this, we're going to be really terrific at it. It's not going to go away likely, and it should become part of who we are to be prepared for the next round.
It's such a pleasure to have somebody that knows about OSHA. One of my dear friends unfortunately passed away during coronavirus, from the coronavirus, who was, my go-to person for OSHA.
Sorry, John.
So while I've got you, and I think Jeffrey will feel the same way, what are some other things that surgery centers really need to be keeping on top of with regard to OSHA?
So I think in our space is so if you think about who OSHA is and what they do, their goal is to keep the employees safe, establish a safe workplace environment. And that's really the goal. And that's a great goal. Mm-hmm. So aside from the respiratory, it's the exposure protection program, right? You want to have a tight exposure protection program that's for blood and body fluid exposure, be it a splash or a stick. You want to be ready to go if there's an event in real time to have be proactive and not reactive. You should be poised, have a partner that you're going to send your staff out for assessment, have your blood draw kits ready to go. Be prepared on how you're going to address your source patient. It should be ready to go. Everyone should know what it is, where it is. Your weekday staff, if you work weekends, who often are per diem crew, they should all know. The last thing you want is to have an exposure and a frightened, potentially exposed individual who no one knows what to do with them. So exposure control plan in the center is really paramount.
And we're going to end with the other point that I want to make, and that is that OSHA is just not always about N95s, nor is it only about bloodborne pathogens, but there are still all those other OSHA rules that we have to follow too. Do you have any insights or any comment about that?
Yes, absolutely. There's many of them, certainly more than an hour's conversation.
Right.
You get a full day event, and their website is fabulous. They have a comprehensive website. There's an ASC checklist specific to ASCs. I think it's a really valuable tool to take a look at. And yes, John, there are many. And they want to help us. OSHA, they also have a consultation program available in every state. They'll come onto your site for free, and they'll do a citation-free survey, and they'll consult with you, identify hazards, and help you step through putting an action plan together to correct them, which is a great program.
And we'll put some links on for the podcast notes for this too. Thank you, Dory, for bringing that up. And I absolutely agree with. We develop our programs at Age Strategies based upon the OSHA website.
Yes.
The information's up there. The information's free. You don't have to pay for it. You don't have to go out and pay a high price unless you want to. To have a consultant come in. Though we appreciate that, to look into it. A lot of that information is freely available there, and you really, even as an ASC, you should be visiting that site regularly. Thank you, Dory.
Yes, you're welcome.
So I have Sherry Eckert-Burr. We've been having a lot of technical problems with getting her voice here, so I'm sorry that the sound quality won't be that great. But welcome, Sherry. You did a great presentation on high-level disinfection of endoscopy equipment, basically, in the endoscopy area. And I have with me Lori Rodericks, who is far better able to ask questions about this. I know she was bugging you and your partner in the session about this. So can you so I'm going to call on Lori to ask the tougher questions here. But can you give us an idea or kind of tell us what you feel are the big takeaways from your session?
Well, I feel like, thank you for asking me. I feel like one of the important things that we discussed yesterday was that it's not all on one person to find where cross-contamination can happen, and that it really does take a team and everyone being vigilant to have best practice anywhere that you're working. And, some of the strategies we discussed were just ideas that they could use that would help make their work easier in decreasing cross-contamination and keeping themselves safe while they're doing it, as well as preparing instruments that are safe for their patients.
On that note, I have a question, and I did pose it yesterday, and your colleague Ian was very nice in responding to me, and I'm looking for the hard support, but I've been in a number of centers, and many of them use a product that is, I don't want to go on record for the product, but it's kind of like a bag that you would put your scopes in, and they use that for transporting their scopes from the procedure room to the the processing area of the center, and it causes me a little angst when I see that happening, just because I was under the impression that it should be a hard container that's impervious, leak-proof, has a lid, is labeled. And, many of the centers are putting the biohazard label directly on the bag. But when Anne responded, she said that it does not meet the guidelines and the standards. Now, the company sent me a document that tells us that it is in compliance with an OSHA 1910.1030. And I was looking all over yesterday to find that proof or, that support. And the only thing in the OSHA that I could find regarding the 1910.1030 was more so for sharps. And there was actually a question posed by someone in the OSHA thing regarding how they transport their equipment, because they must transport out of their center and they use a hard container and blah, blah, blah. And are they transporting their equipment appropriately? And the response was that it's preventing sharps injury. So yes. But it's not just about sharps injury. It's also about potential cross-contamination and exposure and splashes and whatnot. So I looked in AORN today, and it doesn't specify that it has to be hard-sided. And that's what how Anne had responded. So I'm not sure where I can find that. I will call my AORN hotline next week, and they'll cringe when they see my phone number. But I'm just having a devil of a time finding that. And reached out to SG&A today.
Okay, well, let me give you a little bit more context in what you covered. And I mean, your impression is right on. So please be aware of that. But in AMI, in AORN, and it is under, I don't know if it's recommendation 3 or recommendation 4. I forget exactly where they go to point of use treatment, that they discuss that it should be in a rigid, puncture resistant container. So not necessarily, they say rigid, puncture resistant. Now, it does not require a lid, but it does require that it be covered. And SG&A also suggests this. And those are the 3 main organizations of maybe the top 5 that give recommendations for flexible endoscope processing. So I can send those to you. If you'll text me your email, I'll be happy to share that information and the exact citations for you. But what it does is, like you said, it protects the people with that universal biohazard symbol so that people see you're transporting contaminated medical devices of some type. But it also prevents leak spills. And if you've ever been in the ambulatory surgery centers, and it's not just there, it is, I do this worldwide, and I see them using the cinch pads. And you would be surprised how many times we see the tip of the scope that is very unwieldy and sort of has a mind of its own. Mm-hmm. And it will creep out of that cinch pad, and it'll be dripping stuff down the hallway behind people. So it doesn't contain it as well as it should.
I actually had that situation occur in one of my centers, is that I was explaining to them that they needed to have a hard and I'm going to bring Doria into in this a second here. I was walking down the hallway with them as they're carrying the cinch sack down the hallway, and they said, well, there's no problem with it. It contains all this. And I said, well, look behind you. And behind was this trail of fluid. I don't know that it's really possible to control it if, that 90% of the situations you're going to have a problem. And Doria, to that point, you're going to have an OSHA issue because now you got a tripping hazard in addition to the whole.
Well, there's another side to that, John.
Yeah.
And that is when you have that rigid sided container, it protects the scope from damage. And we actually have people in hospitals that have done studies and looked at the significant savings in not having scopes damaged, because if you've ever seen people carry instruments, they're not always real vigilant in the way they handle them. Yeah. And those scopes are long, they're unwieldy, and many times people are not taught how to handle a scope so that it doesn't get away from them. And in those cinch pads, they're very nice in that they have an absorbent pad in them. So we really encourage people to use that absorbent pad not only for during the procedure, but then after they've done their point of use treatment, to absorb any residual moisture so that it doesn't leak out when they put it into that rigid container. And it adds a little extra layer of padding for the scope. So again, you're decreasing the opportunity for damaging your scope and protecting from leaks and spillage, and then covering it and making sure that other people are not exposed.
Yeah, I guess the only problem that I have is in that AORN standard, it says leak-proof, puncture-resistant, and large enough to contain all contents. I don't see rigid anywhere.
So, Lori, I agree with you, right? There's a lot of wiggle room, if you will, for interpretation. We think about best practice and infection control. Cost savings, yes, but we kind of want to pick and choose, right, when we're going to apply, prioritize cost savings over perhaps infection control. And a couple of things to think about when citing the organization, your infection control program. If you're going to cite a particular program, you want to be sure you're citing a program that you can actually live up to all of their requirements. From an OSHA, so there may not be a language in an OSHA standard that says, gee, you have to transport your scopes in a rigid container. OSHA has an out, if you will. They have what's called a general duty clause that they can cite. And if there's a recognized hazard and there's a known fix, so they could cite under a general duty clause for saying, hey, we have a hazard here with, body fluids dripping down the hallway. And if you put this in a tight, hard-covered box, you'll be keeping us all in good shape. So we may not always find it in OSHA, the verbatim, but they have this out, if you will, the general duty clause.
So, and I'd like to add something else to that. We've been working on the AMI revision for ST91, which I think we finally come to a final revision of it, which should be published. And the new guidelines coming out, both AMI and AORN this year is looking at revising their endoscopy reprocessing, and both of these guidelines are going to be more prescriptive and not as vague as they have been in the past, because we haven't had evidence. And now we've had people that have done studies, they've looked at it, they've actually published their research or their quality improvement projects so that other people can learn from them. And I think that's going to be included in, I know it is in AMI, going to be included in these new publications that will be published. AORN will be published next year, and AMI should be published this year.
Well, I could give both of you like very huge air hugs. Only because it's very difficult when an organization shows you this thing from the company saying it's okay, and it's like, but it really isn't safe. You don't understand.
Well, here's another thing, too. And, I am an OR nurse for many years, and I have always had trust but verify. And just because somebody puts something in a letter on a letterhead, that does not add validation for me that this is an acceptable practice. I want to know what their evidence is behind it that shows that this is safe and there have been no leaks. There have been little to no opportunity for cross-contamination, for injury to a patient, or damage to the piece of equipment, or to the person that has to do the handling of it. So the evidence is extremely critical, not just the letter somebody has signed saying, oh, it's okay to do this.
So I'd like to actually bring all of our panelists in, and this has been great because there has been great dialogue. I'm going to ask Ann to join us again too. Ann, of course, talked about peer review, but as I'm listening to this conversation going on, a couple things come to mind. Manufacturer's instructions and how sometimes they conflict. Lori, to your point, the manufacturer's instructions in this case are conflicting with other regulations out there. We have to keep in mind, who is the AHJ, who's the agency having jurisdiction here. So for example, for the situation that they're talking about, that cinch sack, whatever, bag, whatever it is, the manufacturer is giving a reference to OSHA, but OSHA in that particular situation doesn't have total jurisdiction. And certainly when, Lori, to your point, it seems like they were quoting the wrong section. Again, that's why I bring Dorian into it also, because they were quoting the incorrect section of that regulation. So, we as surveyors, and Lori and myself, we're always saying, read the manufacturer's instructions, but we probably should always put a codicil into that. We need to use common sense, too.
It should make sense in our space and what appears to be and known to be, evidence-based best practice.
Yeah, if you see fluid leaking down the hallway, there's just so many problems.
John, there's another resource that you might want to consider is Sylvia Garcia there at the Joint Commission. And, she's an infection preventionist, and she has been very open in giving information about what they're looking for when they do their auditing, and they start with the regulatory, and then they go to the instructions for use, and then they go to guidelines, and they have a very specific prioritization of what they look for. So,
good point.
And she's a wonderful resource.
I'll try to scope her out.
So let me ask another general question for everybody, just putting it out there. So where are we going from here? I am tired of talking about COVID-19. I think we're beating that dead horse. But the question really is a little bit more general here. What is the future of regulations? We know we have a new administration in there. We know we're waiting for some new CMS regulations. We know the agencies are out there to make sure that we are protecting the public, protecting our patients here. What do you think the ramifications of, in other words, how is this all going to affect our regulatory environment? And Doria, a good question for you is how frequently do you think are we going to start seeing OSHA inspectors out there? We haven't in the surgery center industry for a while, but are we going to see that more frequently?
So there's been lots of communication to the field, the OSHA field teams. If you go on their site, really interesting memos where they ASCs are on the radar. And there's lots of information out there that it's interesting that they've been educated to use discretion early on in the pandemic. They were educated to use discretion when they were assessing programs, and they have their finger on the pulse as to the updated guidance as relates to when is supply chain opening up. And then they get the updated education to, okay, they all should be in good shape and meeting the requirements of the standard. So I think that ASCs, in as much as the hospital setting, are fair game, if you will, open for anyone to walk in the door. To your question, John, of where we are going now is, New York State has something on the table looking toward the fall of 2021 for employers to allow employees to create a safety committee of their own. So that's
called the HERO Act that you're referring to.
HERO Act, yes, thank you. So that shaping our worlds a little differently.
Yeah. We've been trying to get our clients a little bit prepared for that HERO Act. And Jeffrey, to that point, during the fall conference, we definitely have to have a speaker. Hopefully by then we'll start to have some regulations. Right now it's just in law. The regulations haven't been produced yet for this, but as Doria indicated, it could have some significant impact on our surgery centers and another layer in addition to what we already have.
John, have you done a poll on one of your podcasts asking people if they've had any OSHA visits? I think because your podcast has a national reach, and I'd be really curious. You remember a few years ago, well, it's probably been 5 to 10 years ago now, when the government allocated money for 5 states to have OSHA inspections. And they were looking for whether your employees were protected. That was a big deal. Some of my centers had those OSHA inspections, and it was tough because they stayed for 2 days and they looked at everything. But I'd be curious how many people, is it ramping up or is it still at the early stages?
Right, and I agree. And we have not heard yet about any OSHA actions. I think right now they're definitely in the hospitals. We know that, and I think it's low-hanging fruit too. Remember, so one point we probably should make here is that when OSHA comes out and does a survey, it's not like Lori, Ann, and I going out and doing a survey. We have no authority to fine people, and it's only a couple states that actually do fine if there is a violation of the state regulations. But OSHA, on the other hand, can have some significant fines out there.
To the tune of over $4 million as of January 2021 in the healthcare setting.
Right. Yeah. So, I mean, and the individual, and then it's by incident too. So it's not just, depending upon the type of citation, it could ramp up very quickly. I mean, literally put a surgery center out of business. And that's one of the reasons that I just really caution all of our listeners out there about being very careful with those N95 masks and your use of it. And the fact that they don't all understand right now that they can only be used basically for a short period of time. You can't reuse them at this point.
Aren't you also finding that the fit test is just non-existent in a number of the centers? Even though they have the N95s, they're just simply not doing fit tests.
Yes.
Yeah, that
very
is
difficult to find too.
Yeah,
a lot of centers think they're grandfathered, that they don't have to do that because there was that temporary, not so much a waiver, but a good faith effort was accepted. But it's well past good faith now.
Right. Well, and making sure that you're doing it on the specific model of respirator that you have in your center. We have one center that bought, 5-10 different models of it. They're fit testing like constantly in order to be able to move back and forth between the different models. You have to use a separate fit test for every model or every brand that you use.
Yeah.
And we can work with our hospital partner. If some of the staff are in the hospital and they're fit tested with the same model that you're using in your center, we certainly can, network and borrow a copy of that document. That's acceptable.
Right. As long as you have all that information in house, that you can't say, well, you're going to have to go to the hospital to get that information. You have to have a copy of that information available.
Right. Exactly.
In your center. So. Okay, and I promised I was not going to spend too much time on N95s. This is good, because I think we've been talking quite a bit about endoscopy, too. Any other last-minute thoughts about the regulatory environment that we're walking into?
One of the things I'd like to bring up is, as many hospitals as I am, I see there is a definite lack of education on many of the staff members' parts as to the different types of regulations and why policies and procedures are the way they are and how those decisions are made for the practices that they have. We still see a lot of people we've always done it that way, without the supporting education underneath of it to say, well, okay, that may be acceptable practice, but why aren't we striving for best practice?
That's a very good point. And actually, a couple episodes ago, those regular listeners out there know that we have now a staff edition of the podcast. And that was exactly what we wanted to talk about, is helping, the staff edition is meant for in-services for our surgery centers. It's become very popular. And one of the editions, or one of the episodes we did, was about the regulatory environment in which ASCs exist. And that all those regulations are out there. They're available for anybody. You don't have to pay to get them. You can look at them on the internet. But making sure that that staff understand the heavy regulatory burden that we have, and that none of us as a surveyor, you can't say to me, even though they try, that we've always done it this way. That is not. If they feel that they're going to avoid a citation by saying that they've always done it that way, that's absolutely not the truth.
You know what? Also, to piggyback on that, I think if a center wasn't cited on it in a prior survey, they feel like they're okay. And unfortunately, that's not always the case, because the surveyor is looking with different eyes every time they go.
Yeah.
Just because I wasn't cited prior doesn't mean that the next surveyor is not going to see that I'm not doing things best practice or, safest manners, that sort of thing. So it's
or we get the surveyor was here and they never said anything about what we're doing, so we're going to continue to do it.
Right.
Exactly.
Yeah, very good point. Well, and you're looking at, our listeners are hearing 3 surveyors. I will tell you that the 3 of us, we don't care. Am I correct, everyone? We don't care what the prior survey did. Sometimes we don't even see what everything that the prior surveyor said. We're going to cite whatever we see, so be prepared for it. I do not tell me that it was never cited before. I do want to thank our 3 speakers, Ann, Doria, and Sherry. This has been a pleasure to be able to interview you, and thank you for your time. I appreciate it.
Well, thanks for having me.
Thank you.
Thank you.
Thanks, everybody.
Thanks. Bye-bye.
Thanks. Bye.
We would like to thank our sponsor, Ambulatory Healthcare Strategies, the nation's leading regulatory compliance resource for ambulatory surgery centers. For more information about their services, please visit ah-strategies.com, email them at info@ah-strategies.com, or call John Goehle directly at 585-594-1167. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your comments and questions. Please email us at comments@ascpodcast.com.